Welcome, everyone, to vpod.ai. We're about to embark on another deep dive, taking your curiosity and our research to uncover some fascinating insights. Today, we're exploring a specific health challenge. It's one that impacts many lives, but is often, well, misunderstood: hairy cell leukemia. Before we dive in, just a quick but important note. This deep dive is sponsored by Stonefly. They're your trusted solution provider and advisor in enterprise storage, backup disaster recovery, hyperconverged VMware, Hyper-V, Proxmox cluster, AI servers, SA365, which is a turnkey security appliance, plus public and private cloud. For more information on their comprehensive solutions, be sure to check out stonefly.com. Okay, so our mission today is really to demystify hairy cell leukemia. We'll look at what it is, how it's diagnosed, the various treatment paths available now, and what life actually looks like for those living with it. You've shared some really compelling material, and honestly, there are some surprising, quite hopeful facts waiting to be unpacked.
Indeed. It is a rare condition, and the depth of information available now really offers a truly hopeful perspective. We'll examine the nuances of diagnosis, the evolution of effective treatments, and how understanding the underlying biology has just fundamentally transformed care.
Okay, let's get into it then. What exactly is hairy cell leukemia for someone just hearing about this for the first time?
Right. At its core, HCL is a rare, slow-growing cancer. It affects the white blood cells, specifically a type called B lymphocytes. It was first described back in the 1950s, and it got its name because these changed B cells, they actually look hairy under a microscope. They have these fine, sort of hair-like projections.
Hairy cells, that really paints a picture. How common is this condition, really? Is it something people encounter often?
No, it's quite rare. It affects about 1,100 people in the U.S. each year, and it primarily affects men, often those of white or Western European descent. The average age when someone's diagnosed is around 55.
So, rare, mostly men, average age, mid-50s, and it's a type of blood cancer. Does it, behave like other cancers people might be more familiar with?
That's a really good question. While it is a malignancy, a cancer, the key thing is it's typically not life-threatening if it's treated. The malignant cells, they infiltrate the bone marrow, the spleen, and the liver. And this compromises the production of normal red blood cells, white blood cells, and platelets. But, and this is crucial, many patients can live for many, many years with this disease. That's a really important takeaway.
You mentioned earlier there's a variant form of HCL. Is that just sort of a subtype or something different?
No, and this is a really important distinction, especially for diagnosis and treatment. There's something called hairy cell leukemia variant, or HCLV. It's actually a separate and generally more aggressive disorder. Biologically, it's not related to classic HCL. It tends to affect an older population, median age about 71, and unlike classic HCL, it doesn't show that preference for men. Knowing the difference is critical. So thinking about diagnosis for classic HCL, it relies on several key things. Seeing those hairy cells morphologically is crucial, yes, but the definitive confirmation, that often comes from a bone marrow biopsy.
Okay, so it's definitely more involved than just looking at a blood sample under a microscope then.
Exactly. And in addition to the biopsy, there are specific markers on the cells. We identify these through a process called immunophenotyping. Think of it like checking cellular ID badges. Classic HCL cells typically express markers like CD11C, CD103, CD123, and CD25. This pattern gives an immunologic score of 3 or 4, helping confirm it's classic HCL.
And this is where it gets really interesting for me. There's a specific genetic link, right? That's been a major discovery.
Absolutely fascinating, yes. In over 95% of classic HCL cases, there's a specific genetic cause, the BRAF V600E kinase activating mutation. This mutation is like a switch stuck in the on position for cell growth. Finding this mutation is a critical diagnostic marker. And, importantly, it has opened doors for highly targeted therapies. It's also worth noting this mutation is absent in HCLV, which is another key difference.
How do people usually find out they have HCL? Does it typically present with, sudden severe symptoms?
Often, no. Because it can progress very slowly, many people are actually diagnosed incidentally, maybe during routine blood tests for something else entirely. They might have no symptoms at all. When symptoms do appear, they're usually related to the affected organs like the spleen or because of the low blood counts.
Right. And what are those common symptoms doctors or patients might notice?
Well, things like a feeling of fullness in the belly, maybe discomfort, that's often due to an enlarged spleen.
Yeah.
Fatigue is common, easy bruising, recurrent infections, maybe general weakness, or even unintentional weight loss. And the blood tests might show anemia, low red cells or low white blood cells, specifically neutrophils and monocytes, and low platelets too. Which brings in a really important point. If it's slow growing, does everyone diagnosed need treatment right away?
That's a great point. My understanding is that often a watchful waiting approach is actually preferred. Is that right?
Yes, that's absolutely correct. Not all patients need immediate treatment, particularly if they are asymptomatic, feeling well. Starting treatment too early can actually increase the risk of infections because the treatments can temporarily weaken the immune system. So treatment is typically advised when blood counts fall significantly, say neutrophils below 1.0, hemoglobin below 10, or platelets below 100, or, if the spleen becomes significantly enlarged and causes pain, or the patient experiences really severe fatigue or frequent difficult to manage infections.
Okay, so when treatment is needed, what have the options been? What's been the standard approach for years?
For the past 30 years or so, the cornerstone of treatment for classic HCL has been chemotherapy with what are called purine analogs, specifically two drugs, cladribine or pentostatin. Both are highly effective. They achieve complete remission in about 80 to 90% of patients, and these responses can last for many, many years.
Can you tell us a bit more about those two drugs? How do they differ?
Sure. Cladribine is typically a shorter treatment course, often given over just 1 week, maybe as an infusion or sometimes injections. But the recovery time for blood counts might be a bit longer. Pentostatin is administered over several months, usually every few weeks, and it's generally considered a bit gentler on the bone marrow. Both, however, can cause that temporary drop in blood counts and a more prolonged suppression of the immune system. This increases the risk of infections for a period. That's why patients are often advised to avoid live virus vaccines, like the older shingles vaccine, Zostavax. But killed virus vaccines like the flu shot or the newer shingles vaccine, Shingrix, are safe and actually recommended.
Okay. And what if those initial treatments don't work as well as hoped, or if the disease eventually comes back, which you mentioned can happen?
Right, relapse can happen eventually for many patients. If HCL returns, it can often be treated effectively again with the same purine analog, especially if the first remission lasted a good long time, typically, say, 2 years or more. However, when standard chemo isn't effective initially, or for cases that relapse quickly or become refractory, meaning they don't respond anymore, that's when we turn to newer, more targeted therapies.
This sounds like where a lot of the recent progress has been. What are some of these newer targeted approaches?
Definitely. Given the BRAF V600E mutation we talked about, the development of BRAF inhibitors like vemurafenib has been a huge step forward. The material indicates that vemurafenib, sometimes used alone or perhaps with rituximab, has shown good evidence moderate strength for treating relapsed or refractory HCL in patients who have that BRAF V600E mutation. It directly targets the faulty protein made by that mutated gene.
Can you give us a bit more detail on vemurafenib? What did the study show?
Certainly. There were key phase 2 clinical studies, one in Italy, one in the U.S., that looked at vemurafenib as a single agent. Patients typically received 960 milligrams orally twice a day for up to about 16 to 24 weeks. The results were really quite striking. Overall, response rates were reported at 96% and 100% in those trials. Now, it does have side effects. Common ones include skin issues like rash and sensitivity to sunlight, plus joint pain, fever, sometimes elevated bilirubin. Interestingly, some patients develop secondary skin cancers, like basal or squamous cell carcinomas, even superficial melanoma, but these were usually managed with simple excision. About half the patients needed a dose reduction due to side effects. But a key advantage highlighted is the lack of significant infectious complications. Because it's not myelosuppressive, it doesn't heavily suppress the bone marrow. That's really valuable for these patients. And while 960 milligrams twice daily is the standard dose, some case studies have reported success with lower doses too.
Okay, that's really promising. What other targeted therapies are out there or showing promise?
Well, there are BTK inhibitors like ibrutinib. These are usually taken daily as a pill and are useful options for patients whose HCL recurs or doesn't respond well to other treatments. There's also moxetumomab pasudotox. That's an anti-CD22 immunotoxin, so it targets a different protein on the HCL cells. It's approved for patients who've already had at least 2 prior systemic therapies. In its main study, it showed a complete remission rate of 41%, which is significant for that heavily pretreated group. But it can have serious side effects, including something called capillary leak syndrome, so it needs careful management. And combination therapy, for instance, using cladribine together with rituximab, has also shown promise, potentially leading to longer-lasting remissions, especially for patients who relapse relatively early after their first treatment. And just for context, historically, before these highly effective drugs, doctors sometimes use interferon, which is an immune-stimulating drug. And even surgery to remove an enlarged spleen, a splenectomy, was more common. But now, with the excellent results from current drug treatments, these approaches are rarely used, maybe reserved for very specific, uncommon situations.
It definitely sounds like the treatment landscape has evolved dramatically. But what about potential complications, either from the HCL itself or maybe the treatments?
That's right. Even with successful treatment, there can be challenges. The main complications from HCL itself often stem from those low blood cell counts we discussed. So that can cause ongoing fatigue, an increased tendency to bleed or bruise easily, and importantly, a heightened risk of infections, bacterial, viral, or even fungal infections. The disease affecting the spleen can also cause persistent pain or that feeling of fullness. And some studies, though there's some debate, suggest a possible increased risk of developing other secondary cancers later on in HCL patients. It's not entirely clear if that's due to the HCL itself or maybe long-term effects of treatment. Also, autoimmune disorders, like certain kinds of arthritis, seem to occur a bit more frequently in people with HCL.
Okay, so there are definitely things to manage. But despite those potential challenges, there's some incredibly positive news regarding the long-term outlook, isn't there? This feels like the real game changer.
This is truly remarkable, yes. There was a comprehensive study from Austria, looking back over 35 years. It followed HCL patients who were treated mainly with these effective purine analogs like cladribine or pentostatin. In the conclusion, HCL patients treated effectively have a normal life expectancy. It's comparable to the general population matched for age and sex. And this held true regardless of their age when diagnosed, whether they'd had treatment before or even when they were diagnosed over that 35-year period.
Wow. That's an incredible aha moment. It just completely reframes what a cancer diagnosis like this means. It shifts it from potentially life-limiting to, well, manageable.
It fundamentally shifts the conversation. Exactly. From what was once seen as a potentially fatal illness to, for most people, a manageable chronic condition. And even though, yes, most patients will probably relapse eventually, consistent long-term disease control is typically achieved through retreatment, often with the same effective agents. In fact, some patients experience incredibly long periods without needing any treatment at all, some remaining treatment-free for over 10, 15, sometimes even 20 years after their first therapy.
That's amazing news. Now, for you, our listener, or perhaps your loved ones who might be grappling with this diagnosis, finding support is so important. Where can people turn for reliable information and community?
There are excellent support systems available now. The Hairy Cell Leukemia Foundation, for example, is a fantastic resource. They offer things like educational webinars featuring leading hematologists, community roundtables where patients can connect and share experiences peer-to-peer, and even full-day patient seminars for networking and hearing directly from experts. They also have specific initiatives like a women's group and targeted outreach programs for Hispanic and Latino communities, which is great to see.
So it really emphasizes that it's not just about the medical side, but about providing that holistic support network for patients and their families.
Absolutely. The foundation also provides an Ask an Expert portal, which is great for getting factual information and potential referrals. They have comprehensive info on ongoing clinical trials, and there's an online patient community forum, too. They're also working on expanding an international patient data registry to help drive future research, although I believe it's paused for some technical updates right now. But that kind of data is invaluable for progress.
Looking ahead then, connecting all these dots, what stands out to you as the biggest opportunity, the most exciting area for future research in HCL?
I think if we look at the bigger picture, the most exciting avenue is the continued exploration and refinement of chemotherapy-free approaches, really leveraging those targeted therapies we discussed. The focus is shifting more and more towards treatments that not only control the disease very effectively, but also minimize long-term toxicity and, crucially, long-term immunosuppression. It's all about improving not just survival, which is already excellent, but enhancing the quality of life and ensuring the best possible long-term outcomes for patients living with HCL. Precision medicine, really.
We've certainly taken a deep dive into hairy cell leukemia today. We've gone from its unique cellular characteristics and how it's diagnosed, all the way through to the incredible impact of modern treatments and that remarkable long-term outlook. What stands out most profoundly to you from all of this? What's the key message you'd want our listener to take away?
I think the most powerful insight really is that transformation in outlook. For rare cancer that decades ago might have been associated with a much grimmer prognosis, the advances in understanding its specific genetic basis, like that BRAF mutation, and then developing treatments that directly target that biology, mean that a diagnosis of HCL today, for most people, comes with a realistic prospect of a normal life expectancy. It's just a phenomenal testament to persistent scientific research and the power of individualized, targeted care.
So, what does this all mean for you, our listener? Perhaps it's a powerful reminder that even when faced with diagnoses that sound rare or complex, the landscape of medical knowledge is constantly evolving. It's offering new pathways, new strategies, and fundamentally new reasons for hope and wellness. So, keep asking those questions, keep seeking out the knowledge that empowers you on your health journey. Thank you so much for joining us on this deep dive. And finally, before we go, just one last reminder from our sponsor, Stonefly. They're offering 100 TB immutable and air gap SSO NAS for $8,995. That's a really powerful and secure solution for your critical storage needs. Check them out at stonefly.com. Until next time, stay curious.